Oh, thank you, Fiona. I should point out, not that I'm trying to get myself out of a tricky situation, is that I wasn't the journalist in Private Eye who wrote about the scare in MMR. It's interesting, Private Eye. It's got its 50th anniversary this year, and it has these separate little groups where people write under pseudonyms. It's sort of with the house style. When it started in 1962, there were lots of famous lawyers who would leak information. There were architects, there were people working in local government, even doctors. And they found out if you wrote under your own name, your career was pretty much knocked out very soon. So they made people write under pseudonyms, and mine is MD. And I always wrote supporting MMR. I said I'd given it to my kids. I thought it was entirely safe. And in the back of the magazine, interestingly, you would expect an investigative journalism magazine to favour the little person, favour the parents who may have been damaged by this evil vaccine against the big multi-billion companies. And to be fair to Private Eye, the one thing they always do is they always publish letters. So while this debate was going on, they sided with the pro could MMR cause autism lobby. But while it was going on, they always published the letters defending the vaccine, saying how safe it was. And when finally they realised they got it wrong, Ian Hislop phoned me up and said, "You've already supported MMR, will you actually write a piece saying actually we got it wrong?" And when we should have ducked out, because that's the other issue for investigative journalism, you have all these interesting stories and sometimes you back the wrong horse and sometimes you've got to put your hand up and say, "We've backed the wrong horse." And I argued quite strongly they should have done it when the first Cochrane review came out on MMR and certainly when the second one came out. They're reasonably good. They're probably better than the Daily Mail, I would suggest. Publishing apologies. But if you read, there's a really good book, The 50 Years of Private Eye, and they actually, no holds barred, they've unashamedly written a story about MMR and how they sort of backed the wrong horse. But there's the danger there for investigative journalism because you're starting, and the media loves anecdote, you're starting a story of somebody could be harmed. Proving cause and effect is really difficult. I could say today that penguins cause autism. If there's no research base, what are we going to do? It's going to take quite a few years to actually refute my hypothesis that penguins cause autism. And if I've gone on a big press conference and say we should ban children ever from going anywhere near penguins at zoos, I can create a media health scare, it can Twitter, it can spread like wildfire. It's very easy because of the difficulty of proving cause and effect. It's very difficult to disprove those theories. So I'm still writing for Private Eye. I do that generally on Tuesdays. I work as a GP on a Monday in Knowle West, which is quite a deprived area of South Bristol. I start doing investigative journalism on a Tuesday, and then I start doing comedy gigs towards the end of the week. So I work my way through, trying to get funnier as I go through the week. I would strongly endorse Fiona's position of getting a closer link between investigative journalism and medical journals and the NHS. My experience of working with NHS whistleblowers over 20 years is that actually good, constructive investigative journalism is the only thing that holds the NHS to account. All the NHS regulators, whether it's the Care Quality Commission or the Healthcare Commission or the Commission for Health Improvement or whatever you want to call it this week, they're like sort of fielders on the boundary. They sort of sit out there on the edge and they haven't really got a clue what's going on in the centre. Often it's frontline staff who raise concerns about something. And rather sadly, the history I have of whistleblowers in the NHS is they're pretty much still slaughtered. Despite the Public Interest Disclosure Act and the protection that's supposed to be offered to them, we did an investigation recently, and again, we used Channel 4, the Centre for Investigative Journalism, on the amount of gagging clauses that are still paid out in the NHS. So basically, you'd raise concerns about anything in healthcare. Could be a new prosthesis, could be a dodgy drug, could be a doctor that you think is incompetent. It's very easy for your employers to go through your medical records and find out a mistake that you made, because we know we've all made errors in our job, and they go through there and they find out someone who's made a mistake, and they counter-smear you. They say, you're only raising these concerns about this particular doctor or this particular prosthesis because you have made a mistake yourself. Therefore, we're going to take this to employment tribunal. And then you lack, generally, the legal cover to support you, and they make you sign a compromise clause or a gag. And in some cases, that prevents you from ever speaking about it to anyone ever again, apart from your immediate family and perhaps your MP. We're working on a story at the moment. It's the biggest gagging clause ever, of probably several £1 million of a chief executive, former chief executive in the NHS. And he's not only got to gag himself, he's got to gag all the consultants who supported him, who pointed out that patients were dying because of religious adherence to a 4-hour waiting time in Casualty Target, when it was clearly an unsafe thing to do. And the NHS has spent millions suppressing this, millions in his payoff, millions in gagging not just him, but all the other consultants who raised concerns. So it's a difficult job, and I suppose the one lesson I've learned, and the advice I give to Debs, is that you've got to keep turning it over. It's a little bit like a public health campaign, investigative journalism. You have to keep repeating the message, repeating the message. I remember Deborah talked about Chris Bulstrode. He described the orthopedics prosthesis industry as like the arms trade, and they fly you out to these wonderful locations all over the world. and they spend an absolute fortune on you. And they're totally unevidence-based. And when he made those comments in 1993, we picked them up. I was doing a series called Trust Me, I'm a Doctor on BBC Two. And we did a big story. There were 57 hip prostheses, Heinz 57, that you could have on the NHS. All sorts of combinations between the hip prosthesis and the various bits of cement and capsules. And there are only about 2 of them that were evidence-based. There was the Charnley prosthesis, because of Charnley, the orthopedic surgeon, absolutely religiously followed through all his patients. There was no compulsory register now. I don't think the register now in the UK is even compulsory, is it? Is it still voluntary?
Yeah, it's going to be incentivized.
It is. So the whole process of Trust Me, I'm a Doctor was basically, the subtext was don't trust them just because they're doctors. Ask awkward questions. How likely is it that this prosthesis is going to work? What is the evidence that you can show me that this will work? And actually, when patients start asking those awkward questions, the whole house of cards tends to fall to pieces because there isn't evidence. We recommended the Charnley. We also asked the Queen Mother's orthopedic surgeon which prosthesis they put in the Queen Mother, because you wouldn't put any old rubbish in her. And I think it was something called the Fernley prosthesis, or the Furlong prosthesis, but those sort of the 2 we recommended. And it is interesting. Journalism is just about us being skeptical, being evidence-based, but just asking good questions. Any of us, the skills you have, you learn in evidence-based medicine that you use in journalism. It's about standing up to the system and asking good, important questions, and then just being like a dog on the trouser leg, not letting go until you've got the answers that you want. I think that's absolutely important. So there is a key message there. But the danger always is your temptation is to side with the little guy against big bad pharma. And in some cases, like the MMR story, you side with the wrong side. And then you've got to put your hand up and say, we got this wrong. I'm not a great fan of politicians, but I met Ken Livingstone recently. I was on Question Time with him and Andrew Lansley. It's one of the most embarrassing Question Times there has been for some while. But the thing I liked about Ken Livingstone is he said when he introduced the congestion charge in London, he said, look, I'm going to try this. I haven't really got a good evidence base that it'll work. And if it doesn't work, I'll put my hand up and say, that didn't work, and I'll try something else. That's actually what I want. I want evidence-based politicians who come up with evidence-based health policies. I know a lot of you aren't from the UK, but we have a big debate that's going on in Parliament at the moment over this wonderful thing, which is called the Health and Social Care Bill. How many people here work in the NHS? How many people here have read the Health and Social Care Bill? How many people have understood the Health and Social Care Bill? I got in an argument on Question Time, which is this big political discussion program, with the Health Secretary. This is only one of Volume 2. There are 358 pages and 200 pages of explanatory notes. And I described it as 358 pages of wonk. It's a new noun I've come up with. It's completely incomprehensible. You can't actually understand this. So this is a huge, huge reform program we're undertaking with probably no evidence base. Can anyone think of any good evidence base that shows that this approach to transforming the NHS, throwing all the cards up in the air, who thinks there's an evidence base that GPs lack the balls and the expertise to do commissioning properly? Who thinks there's evidence that GPs will go to hospital and go, we ain't commissioning it, you want to use that prosthesis, it has no evidence base, you can use it, comes out of your budget, we're not paying for it. Who thinks GPs will do that? Good. Who thinks GPs will pick up the 1,000 nice never incidents or things that have no evidence base or whatever and say, you carry on doing this, we're not paying for it? That's basically what commissioning should be. The only way, I mean, if you believe that commissioning can actually get better evidence-based healthcare, it needs commissioners with balls. The trouble is there is no evidence ever, I don't think, that commissioning has changed patterns of behaviour in secondary care. And it's a big leap of faith. You should think that GPs have a fair idea about what their patients might want. I would say patients have a better idea than GPs about what they want. But is there any evidence that GPs can alter that system? I can't see any, and we probably ought to put it out to pilot. We should try and do some sort. We generally don't do randomised controlled trials of political reform. I think at the very least, NICE, or in a body like it, should take on board political reforms, and before we throw all our cards up in the air, we spend £1 billion point something sacking people and re-employing them again. We should actually get somebody like NICE to say, we've looked at the evidence base for this political reform, this market reform, these strategies, these are the ones we think might work, these are the ones there is no evidence base, this is what we think is value for money in the NHS. I've been arguing that for 5 years. I've chaired the NICE conference for the last 5 years, and every year I say, my hypothesis is that politicians kill far more people than doctors. They just do it indirectly. Political reforms, if you get them wrong, cause huge amounts of harm and huge amounts of damage. If you honestly believe, as Bruce Keogh said to you, there is a 20 billion funding gap between what the NHS demands are and what we can provide, then absolutely every penny has to be spent on delivering quality and safe frontline care. To actually waste money on reform that won't work is actually killing patients, to be blunt about it. And so before we go through this huge reform program, I want somebody independent. I don't want Andrew Lansley saying there's been 3 studies somewhere that I've cherry-picked that show some vague correlation between competition and improved health outcomes. I want someone with the same rigor that you look at a systematic review looking at healthcare reform and saying, we think this particular strategy might work. I think what's interesting also is that you have to fit it in with the culture of the country that you're in. There are some countries that accept market reforms. They would hate the degree of political interference we have in the NHS. There was a great saying from Henry Ford. He once said that culture eats strategy for breakfast. And I think it probably eats evidence as well. Unless you can somehow marry your health reforms, you can couch it in a language that buys into the culture of your health system, they're never going to work. How many people here actually, having read what they've read about the health reforms, particularly people who work in the NHS, how many people think, yes, I really buy into this, this motivates and inspires me, this is where I want the NHS to go? Who thinks, you? Who is vaguely optimistic it might work slightly? Who thinks there's a fair chance it'll do more harm than good? It's amazing, isn't it? I mean, I've spoken to audiences all over the NHS. I took this up to Scotland. I was in Scotland at the Edinburgh Fringe this year. And we did a Braveheart demonstration. We were pretending that the English were smuggling this awful bill into Scotland, which has a sort of an old cooperative socialist-style health system. And we got people to stamp on the health and social care bill. Well, the audience screamed, we're mad as hell and we're not going to take this anymore. But they're quite smug in Scotland. It's really interesting. Scotland prides itself on having the most cooperative health service. They would say they're way ahead in integration. They don't bother with commissioning because there's no evidence that commissioning works. They just give each of their health boards a sort of a suitcase full of money. And they say, go off and spend it as best you can and come back and be accountable every now and then so we know where the money's going. So they like to think in Scotland they have the best NHS in the United Kingdom, and they also have the lowest life expectancy, which is quite a trick, isn't it? And I think we know the reason why. How many people here would say they were healthy out of interest? Put your hand up if you think you're healthy. All the healthy people? Excellent. And who's a lonely, divorced, alcoholic bigot? About 50-50, which is what I'd expect at an evidence conference. The reason I say that is we've known since 1980 and before, since the Black Report, we've known that the causes of ill health are largely social, and so therefore are the solutions. If you have no job, no house, no garden, no self-esteem, no reason to live, you're unlikely to pop down to Waitrose for a couple of oily fish and a punnet of sun-dried tomatoes. If you're living in a cardboard box under a bridge, you may forget to examine your testicles once a month after a warm shower. Mind you, I suppose that's all you do if you're living in a cardboard box, but you take my point. You have to give people hope and a great feeling of expectation, a reason to live before you can get them to take their health seriously. And that's the bit we've really failed on. Even under Labour, the gap between rich and poor, some people argue it's got wider. It certainly hasn't got any narrower. It at the least has stayed the same. And one of the clues came when I was in Scotland. I decided, in a slightly English point of way, I had a friend staying with me who wanted a gin and tonic. So I went into the local supermarket to try and buy a lemon. I found a lemon in my Scottish supermarket in the exotic fruit section. It was the only thing in there apart from a pineapple, and under the pineapple it said imported. As opposed to those famous Scottish pineapples that I think they call them corn on the cob. In Scotland, the diet is extraordinary. A sausage in Scotland is one of your 5 a day, fruit and veg. The other 4 are also sausages, I think. I found a sausage with cheese in the middle of it. People know about the deep-fried Mars bar. They have sausages with cheese in the middle. I mean, it is extraordinary. And we know that you've got to do the upstream stuff. My GP trainer many years ago was a Yorkshireman, and he had a wonderful metaphor for working in the NHS. He used to say, life is a pool of shit, and our job is to direct people to the shallow end. We should all have little slow, that should be our strapline, working towards the shallow end. And actually, I've developed the metaphor. I think working in healthcare is a little bit like camping out beside a river. And bodies float down the river all the time. And we dive in deeper and deeper and deeper and pull out the sick and sick and sicker bodies. The really sick people, we pull them out. We spend a fortune treating the untreatable, that nobody has time to wander upstream and look at who's pushing them in. If you go onto any intensive care unit in the country, it's likely to have people in their 80s, and this is in any country, people in 80, 85, slowly having the life sucked out of them on intensive care machines, because we don't have those difficult conversations about what constitutes a good death. We spend an absolute fortune treating the untreatable. When I trained, if you went into a dementia care home and someone with severe dementia developed a chest infection, you would give them a decent death. These days, normally, you fish them back into hospital, they have intravenous antibiotics until we try and cure their chest infection. So we need to have these difficult conversations, not just about evidence, but also about ethics. And I'm not talking about euthanasia, I'm talking about good palliative care I went into medicine many years ago. One of the reasons I went in, I met this wonderful woman who came to our school to speak called Dame Cicely Saunders, who was a founder of the hospice movement. And she said quite simply that the great gift of being human was to be humane. And that really struck a chord with me. She told us wonderful stories of people in their last weeks of lives who'd done wonderful painting, they'd made beautiful music, but most importantly, they'd reconciled themselves towards death. And she was able to do that with fantastic palliative care. And that was a thing that, above anything, made me want to go into medicine. I like the combination of being good at science and actually doing something humane. And if you look at all the challenges facing healthcare, I would say the central challenge is for it to rediscover its humanity. I know that we talk about evidence all the time. Evidence is important. Evidence without empathy, evidence without humanity is hopeless. And if you look at the scandals we've had in the British Health Service, and I'm sure in other health services, particularly in our treatment of the elderly, it's as if medicine has become so process-driven, so given by guidance, so driven by top-down targets, so driven by bullying, in a sense, so driven by a fear of being able to speak out, that, in a sense, it's lost its humanity on the front line. I chaired a conference this week looking at the crisis in nursing care. People came to speak from mid-Staffordshire, but what was evident, and the Care Quality Commission has just done some unannounced visits using nurses on hospitals around the country, is that what has happened in mid-Staffordshire is pretty much endemic in the NHS. We're struggling to cope with increased numbers of patients in hospital. Everybody says that the whole idea of the health reforms, if we integrate care, is to keep people out of hospital, and there doesn't seem to be much evidence at the moment that that's happening. And we've got a real crisis on the front line. But when we talk to all these leaders, all these nursing leaders, about how we resolve that, all of them were pretty clear that it involves leadership above anything else. You know, you need to talk the language of compassion rather than commodity. And that starts with our political leaders. You need, if you want to reform the health service and you believe in it, you need a really gifted communicator as your health secretary who talks wonderful language and motivates and inspires people and wins the hearts and minds of NHS staff and the public. I would suggest we don't terribly have that at the moment. I think we have a free market health secretary. We have a chief executive of the NHS who's a former Communist Party member and doesn't believe that the NHS reforms will work, but because he's a civil servant, he's not allowed to say. And sandwiched in between that, we have a new chair of the NHS board who's part-time, he's never worked in healthcare before, and he finds the Health and Social Care Bill completely unintelligible. So we almost have this, it's like a Bermuda Triangle, isn't it? The dream team. A free market health secretary, a former Communist Party chief executive, and a chairman in the middle who doesn't know what he's doing. So that's the leadership trio at the top. How that will filter down, I don't know. The bottom line is that we will liberate the NHS. GPs will be free to commission care as they think is best for patients. When we started, I can remember going to these meetings where Andrew Lansley, the health secretary, would come round and he'd say, oh, it's all going to be terribly free and you decide what consortium you want and it can be whatever size you want. You're completely free to come up with your consortium. And they all came up with these GP Pathfinder consortia. And they called them silly names. They named them after their daughter or their daughter's prep school. There was the Red House. There was Bexley Clinical Cabinet was my favourite. That's where they keep the whiskey, I think. There was Cumbria Senate, the idea of the Senate and all dressing up in togas. Completely confused patients. Patients haven't even got a clue, didn't have a clue what a primary care trust. You split this all up into GP Pathfinder consortia. Patients who are supposed to be involved in this decision-making really haven't got a clue about the reform programme. And since it's gone on and we've had all these revisions, we've replaced strategic health authorities and primary care trusts. We've replaced them with a national commissioning board, regional outposts of the national commissioning board as yet undefined, overarching clinical senates, which nobody knows what they are, and GP commissioning consortia, now clinical commissioning consortia. So we've replaced 2 levels of bureaucracy with 4. It's thoroughly confusing and nobody knows whether it's going to work. Amidst all this, the hope is that actually on the front line, people will get together and they'll integrate locally. And the other nice thing about travelling around the country is I've actually seen some really good examples of GPs getting together with health and social care and devising programmes for keeping the chronically sick out of hospital, people with dementia out of hospital. The theory, which is interesting, that every healthcare, whatever country you're in, whether you're in socialist Scotland or competitive Kaiser, everybody talks about integration. That's the idea. We don't want to mention competition. We don't want to frighten the horses. We don't want to mention money. Everything is integration, as if it's the solution to everything. And my understanding of it, my best feeling about integration is that we almost need a postcode lottery in health systems. We need to focus on that 20% of patients who take up 80% of the resources, the really, really chronically sick. And we should absolutely lavish not just care, but love and attention on them. We should go out visiting them in their homes. We should make them a smoothie. We should make sure they take all their 28 tablets a day. We should do everything we can. It's like the reverse postcode lottery to target those patients who need it most. That's the only way that I can see we can possibly reduce the health inequalities, and that's the only way that I can see that we might possibly reduce hospital admissions. It needs to be targeted, but that's the one bit of the health reforms I can see working, purely out of desperation because we have no space in our hospitals. I'm hoping that GPs will get together. And there are some good examples of this. Here in Northwest London, the Northwest London Integrated Care Organisation is the largest, I think, in the NHS. And basically, they get consultants to come out of hospitals and see the really, really difficult, chronically sick patient who has 6 comorbidities, really difficult and complex. And these consultants travel out into general practice, and they treat them. They give them hour-long consultations. And they're starting to get good evidence that this is keeping people healthier in the community and out of hospital. So that's the sort of model I would like to see. It'll only happen, I guess, if we have integrated IT. This was another thing we were promised. You have to have the same information technology systems across different parts of the service. I heard the chief executive of Kaiser speak not long ago. Now, Kaiser has caused a lot of a ripple effect in the NHS, partly because the British Medical Journal in 2004 published a famous paper by Donald Light and Michael Dixon suggesting that Kaiser should be the model that the NHS adopted. And people pointed out quite reasonably that Kaiser doesn't have the same research and teaching obligations of the NHS, and they can decide if they don't want to go into Pittsburgh, because it's full of sick people, they can decide not to. So it's not directly comparable. But their model of integrated care and integrated IT, they've spent a fortune on their IT and a fortune getting it right. And the thing that really struck me, he said, is that their consultants have exactly the same access to the notes as the GPs and the people in the community. So if you go to have your cataract removed, your eye surgeon might say, oh, you're due a cervical smear, which might put you off slightly, mightn't you, with an eye surgeon? Or you need to have your blood pressure measured. That's precisely the kind of integration, and we need to integrate the information systems. If you contrast that to my place of work at the moment, I work in a walk-in centre in Knowle West in South Bristol. It's quite a deprived area, and it's one place where you really, really want, because you're quite isolated working there as a doctor, you would like to have integration with GP's notes, hospital notes, social care notes. It's the kind of place you would probably bring a baby Peter or a Victoria Climbier. You don't want to take him to your own GP, take him to the walk-in centre, see an unfamiliar doctor in unfamiliar surroundings, see if you can hide what's been happening. And I have no access. It's quite a high-risk situation for that. I have absolutely no access to notes of casualty, notes of neighbouring GPs, notes in social care. That's, I think, almost unforgivable, given the amount of money that's gone into our IT system. So I don't think we'll get proper integration. We probably won't get proper evidence embedded into the NHS until we have this integrated system. There is there's one system called System 1 in the NHS that allows hospitals and GPs to share the same information. And I met quite a market-oriented GP, and he sees in real time where his patients are. As soon as they go to the hospital, if Mrs. Miggins has gone up to casualty with a paper cut, and it's about to cost him £600, he sends the nurse up in a van to dish her out again before she can be charged. He knows where his patients are in real time. I mean, that's sort of, the innovative. The good thing about GPs is they are quite tight with money in a good way. They recycle paper clips. They don't like wasting money on stuff that doesn't need to be done. And if you give them the opportunity of going in and opening up the books in the primary care trust, or actually asking those questions and consultants, why are you doing this? Couldn't you do this in a cheaper way? The evidence suggests you should be doing this. If GPs can be empowered to do that, if the central fist at the centre of the NHS Commissioning Board allows GPs to do that sort of awkward stuff, I have a sneaking suspicion it might work in places. I think there'll be winners and losers, there always is, and we introduce more competition into the NHS, I think there'll be winners and losers. But aside from all that, I still think the message for health systems is no health system can possibly survive unless people start taking more responsibility for their own health. I think that's absolutely key, and it's probably the most key thing as far as my work as a GP. Probably 50% of the patients I see, the ailments they have are in some way. Self-inflicted seems like a slightly judgmental thing to say, but I came up with this theory that I should redefine myself not as a GP, but as a pleasure coach. I have this theory that we should teach patients how to pleasure themselves in a safe and sustainable way. How many people feel they can pleasure themselves safe and sustainably already without my help? I think it's really important because ultimately we're like rats on a treadmill, aren't we? We're sort of balancing pleasure and pain. That's what we do. We live in a fairly secular world. Most people don't have a particular belief system. And most people, spend their lives balancing risk and harm, pleasure and pain. And my feeling is that if we could somehow get into schools, we teach kids resilience skills, we get their mental health right, we teach kids how to pleasure themselves safely and sustainably, that's going to have the biggest upstream effect. And again, in Baines, where I've been living, my primary care trust, they started a social prescribing model, which I thought was really interesting. with patients who are just a bit miserable, they're a bit tired of life, they don't fit into evidence-based models, there's nothing on NICE to tell you how to treat someone who's just a bit pissed off and lonely. You can prescribe them dog walking, they can go to knitting circles, they can go to reading groups. Very hard to get robust evidence to prove this stuff works. The patients love it. A little bit like the debate you've had on complementary therapies. I would have liked to have heard that. How many people here, despite hearing Edzard Ernst, still think complementary therapies should be prescribable in health systems? One of you? Two of you? Oh, three of you? Yeah. Who is absolutely against it? Okay. Why do you say that, sir? Yeah, tell me, there's no evidence. Okay. How about this? I've come up with these because I have a difficulty with complementary therapy because I have lots of patients who really get on with them. And I would rather my old lady with osteoporosis takes a bit of homeopathy than burns a hole in her stomach with diclofenac or ibuprofen, if that seems to sort her out. My problem with complementary therapies is when I try doing them, I get the giggles. I can't look somebody in the eye and say, you've got too much jitsu in your subu. Or, I'm going to put a needle in your encircling glory, Mrs. Fanshawe. I get the giggles. I've lacked the emotional depth to do this. But actually, there's very good evidence. Ben Goldacre talks about the power of the placebo effect. How can we harness the power of expectation and faith over the human mind and do it in an ethical way without deceiving patients? And a lot of people have argued that we should bring back the placebo. So I've come up with these. These are Dr. Phil's magical healing love placebos. In controlled trials, they're 87% more effective than ordinary placebos. And they harness all the paraphysical healing energy in all the known universes which spiral down through my third eye and out into my love tablets. And I swear, if everyone in this room took one of my love tablets and believed in it, we would all feel better. It treats just about everything: irritable bowel, depression, anxiety, premenstrual syndrome, erectile dysfunction. You can't have one, sir, because the people behind you won't be able to see. But who fancies taking one of my love tablets? Who would like to take one now? Excellent. Have you got anything to drink? Can we get you a bit of water? Have you got a cup of water? They're proven to work. Tell you what we'll do. I'll take one and you take one. How about that? Have you got a glass of water there? No, well, you didn't. It's just you. We'll just get you some water. This will work. We're doing a scientific trial. Excellent. I'm looking forward to this. We'll get 2 glasses. We'll have one each. Make it fair, because that would be unfair, isn't it? It's a small trial. Now, if you take one and I take one, how about that? Is that fair?
Okay, yeah.
Pop it in.
Yeah. Oh, you took yours first.
You can take one. Swallow it. Open wide. Oh, shit, hold on, have you? I can't believe you do. Have you really taken it?
Yeah, of course I have.
I don't know what's in them. I just found them hanging out the Clack Clinic. I've got no idea what's in them. But that's interesting, isn't it? Why do people do what doctors tell them? That's the other thing that fascinates me. Why do we trust doctors? What is it about doctors that allows us to do this? It's just ridiculous. I've no idea. We peek an eye on you. Have we got any doctors in the house? Any nurses? Anyone who's seen a recent episode of ER, please come to the front and just keep that. It is interesting, isn't it, this sort of trust thing that people do. I'm slightly sceptical about tablets. I mean, the reason I'm quite in favour of reintroducing placebos is that, talking about the humanity going out of medicine, I work as a GP, I sit behind my desk, I stare at my computer screen. When I first went into medicine, when a patient came into the room, I would look them in the eye, I'd shake their hand, I'd get their name right, we'd have a giggle, we'd do therapeutic gossip, I used to call it. Back in the 80s, patients came in, you had a bit of therapeutic gossip, a bit of hand-holding, maybe a bit of a hug, and then you'd send them on their way. We didn't measure anything. If they didn't come back, you didn't know if you'd cured them, whether you'd killed them, whether they'd quit in disgust, so long as you left them with a smile on their face and they didn't come back. That was all you were worried about. And then evidence-based medicine came in. People stopped being tactile. How many people here work in any sort of health system at the moment? Okay, and how many people are quite tactile? Who would regularly hug a patient? Okay, good. Who occasionally hugs a patient? Who thinks hugging patients is something that somebody else should do? See, I think touch is really important. Brian, my GP trainer, the pool is a shit man, he retired after 40 years, and I said, sum up your 40 years as a GP, and he said, saved 2, killed 1. No, actually, it was the other way around. But he taught me the importance of hugging. He said there are a lot of old ladies who'll come and see you. They're lonely. They live alone. The only person who ever touches them is the postman as he hands the letters over, or the person in the shop as they give you the change. He was really, really into it. Just gently, a hand on the shoulder, a hand on the thing. We don't do that anymore because we're staring at the bloody computer. I was doing this the other day, and I was filling in the previous patient's quality points. And this patient came in, and I didn't give her any eye contact. She was quite annoyed. She came up behind the computer, and she went, beep-boo, like that. And it sort of flipped me back into a slightly more compassionate. You need evidence-based compassion, I think, is the way to. But it's ridiculous. You know, I was working in a group practice until recently, and my worst day was Tuesday because I always had to do the repeat prescriptions on a Tuesday. And it's this huge pile, 8 partners in the practice. So the repeat prescription pile is about that tall. Half of the patients I've never met. Half of the drugs, to be honest, I've never heard of. Don't write that down. The only thing that keeps it safe is the computer. The computer is the only thing that spots dangerous drug interactions in general practice. If you ever go into a GP surgery and they say, the computers are down, get the hell out of there now. It's the most dangerous place on earth. All the safety work's been done in hospital. There's this huge black box of safety in general practice. You know, we used to have a National Patient Safety Agency that used to have this reporting service. And again, it was voluntary, so it didn't really work. It wasn't really representative. But it was like, for serious events, you're supposed to report it to the National Patient Safety Agency, and they would come up with some sort of plan, and they'd produce safety alerts. Less than 1% of all the reports to the National Patient Safety Agency came from general practice, and nearly all of them from nurses working in immunisation clinics. So GPs work in that black box. They have meetings, they discuss critical incidents, they class near misses, they discuss cancer deaths, but they keep it all in-house. They don't tell anyone. I don't want any scrutiny of that. It's interesting. They scrutinise each other, but they don't let it outside the practice. So I have slight issues about quality in general practice, and I think we should sort out the quality and safety before we move on to the commissioning. But the thing that I find ridiculous is I've got this huge pile of repeat prescriptions, and I had a few hours off the other day, and I thought, I'm actually going to find the person in the pile on the most drugs, okay? I found a woman of 82 on 28 tablets a day. It's a couple for cholesterol, couple for blood pressure, couple for diabetes, couple for osteoporosis, couple for osteoarthritis, 17 for the obsessive-compulsive disorder she's developed since taking all her tablets. And of course, she's on warfarin because everyone is on warfarin, stops you having a stroke. Good evidence base for that, but of course, it interacts with all the other tablets. So the poor woman is coming down every few days for her warfarin levels to be checked, her INR. And despite swearing she's taking her tablets, her INR levels are going up and down like a bride's nightie. Can't understand why, so we do a home visit, and it turns out she gets so confused taking 28 tablets a day that at the beginning of the month she empties them all into one big basket, takes out 28 at random each day. I figured it would even itself out in the end, doctor. I said, that's ridiculous, Maud. What happens if you pick up a handful of red uns? She goes, I'm not stupid, I mixes them up. Which is actually quite a sophisticated way of taking 28 tablets a day. And that's the thing that gets me about all this evidence-based stuff, is most of the clinical trials are done with people on 2 or 3 or 4, maybe 5 comparator drugs. We don't do real-world trials on people on 28 tablets a day. They feel muzzy-headed. They fall over in the potting shed. You know, the way to move this debate forward is to get into real-world data. The one bit of the health reforms I understand, actually, is the outcomes framework. In the UK, they're going to be judging our performance on various outcomes. One is keeping people healthy, good idea. One is getting them better from individual episodes of disease quickly and safely, good idea. Third one, managing chronic diseases better, which everybody agrees with. They estimated if they managed diabetes 1% better in the United States, it would fund universal health care. That's how much money they spend. So if we can manage chronic diseases better, that's good. But quite uniquely in the NHS, they're now finally judging patient experience. Patient experience is now going to be something that, an outcome measure that people are going to be judged on. Whether it's evidence-based, how we measure it, clearly important. But I like the idea that it's embedded there. They've come up with these patient-reported outcome measures for isolated conditions, some of which have more of an evidence base than others. But the nirvana, I guess, is moving on towards what they call patient-determined outcomes. You don't want patients to report outcomes. You want patients to come to you, the new consumers, with their individual health budgets, to say, this is what I want to get out of the system. Can you help me? That's the final thing. Can we move to patient-determined outcomes where patients are actually ballsy enough to doing that? And they probably will only do that when they control the money, I guess. And again, in that sort of market system, the people who are more articulate and the ones who understand risk will be the ones who navigate the system better. So you will need advocates for those who don't have that. But I feel general practice has, in the 10 or 15 years I've been in there, it's lost a bit of that humanity, it's lost a bit of that face-to-face contact. Still, if you do studies, communication studies with patients, the one thing they say, the most important thing for them is to come away with a feeling that the doctor or nurse or receptionist likes them. It's that simple. We've known for years you can be quite a dangerous doctor, but if you've got good communication skills, you can survive. I always argue when I'm doing comedy that I'm more accountable as a comedian than I am as a doctor, because if you do comedy and you don't make people laugh, they don't come and see you. I could be a really dangerous doctor and still have a waiting room full of patients in a monopoly provider. So there's a slight issue there about how we change that. But ultimately, I don't belong to any Royal College, I don't belong to the BMA. The only thing I belong to are patients groups. And it's interesting, when you have minor celebrity status, there's a bit of a pecking order when the charities come according to how famous you are. So I think Madonna, she does breast cancer. Camilla does osteoporosis. Can you guess what I've got? Herpes. I'm patron of the Herpes Viruses Association, not, as I was introduced recently, the patron saint of herpes. And the reason I'm quite happy and proud, we've just incorporated genital warts as well, which is interesting, but the reason I'm proud to support that is because I like supporting the stigmatized illnesses. You don't see herpes much on the front page of the newspaper unless it's that story recently of a man being sent to jail in Northampton for passing on herpes. The Herpes Viruses Association has spent years trying to destigmatize it. And if you look at the history of herpes, it's fascinating. We've all got, 80% of us will have been infected by herpes virus at some stage. We don't know whether it's oral, we don't know whether it's genital, it doesn't really matter because obviously the oral one can go downstairs. It's basically a cold sore gone south, I think, of genital herpes. It's like having chickenpox on your knob. It's not the most fun in the world, and the first attack can be deeply unpleasant, as can occasionally subsequent attacks, but for most people, the first attack is the worst. And it subsequently gets better. It generally doesn't kill you. Obviously, herpes encephalitis can, but generally genital herpes doesn't kill you. And its big problem is the stigma associated with it. Where did that stigma come from? Well, probably it can be traced back to the development of acyclovir, Wellcome, which is now GlaxoSmithKline Wellcome Poland, or whatever they are. They came up with acyclovir, good drug discovery, but wanted to cause lots of media noise. And for some reason, Time magazine in America took the bait, and they described herpes as the new sexual leprosy. And the new scarlet letter on the front page of Time magazine. And people, the depression and the anxiety caused by the diagnosis of herpes far outweighed the physical damage caused by the disease itself. So I was absolutely horrified in Northampton when this, I think he was a traffic officer, was jailed for 18 months for apparently deliberately passing on herpes. Very difficult to know because a lot of people who pass on herpes are asymptomatic shedders and they don't know when they're passing it on. Almost impossible to prove, I would have thought. I don't know the specific conditions of that. But again, to me, it's an example of healthcare losing its empathy. And I think that's an absolutely ridiculous sentence this chap had. We're challenging it at the moment through the Herpes Viruses Association. We're hoping it will be reversed. So that's the first disease I do. I do the Meningitis Trust. I do the Patients Association, which I think is quite interesting. The Patients Association has no funding, so it has to take its funding from the pharmaceutical industry, but it isn't disease-specific, so it won't promote individual organisations. But I think the Patients Association does a good job. But there isn't, and this surprises me in the UK, there isn't really a unified patient advocacy group. We have lots of these small advocacy groups who fight their corner for individual diseases, but we don't have a whole unified group that stands up. Lots of instances of drug company money getting behind patient groups. We're now coming out with health and well-being boards in the latest round of the NHS reform. But I think there's a real need for some sort of unifying patient group to actually get that patient opinion and that patient experience. Driving healthcare reform. My vision ultimately, because most of my work has been about patient safety over the years, is to use patient opinion and patient feedback and relatives feedback as like a smoke alarm for the NHS. I call it a harm alarm. We now have real-time monitors. We can use Blackberries, we can use tweeting, we can use any sort of social network feedback to give people real-time feedback on the quality of care that they're delivering. And that's where I think the real improvements in healthcare, real-time improvements will happen. They tried it, I think, in Whipps Cross Hospital. They gave patients real-time feedback that went straight back to the nursing station about their care, whether they were given the right tablets, whether their food was plonked down out of their reach. The feedback went in real time to the nurses' station and improvements happened immediately. Nurses read the feedback and went, oh, we better do something about this. Again, some patients are better at feeding back than others. But that's where I see the real progress in healthcare coming. It's going to come at the front line and hopefully it will come from patients actually driving change and actually being quite assertive and articulate. How many people here would say that they're quite optimistic about the future of healthcare in whichever country they are? Who are optimists? Who thinks, yeah, it is going to get better over the next few years? Okay, who's a pessimist, thinking actually funding's going to dry up, there's a big recession, we're all going to die, it's terribly miserable? Where are you from, sir?
Peterborough.
From Peterborough. Is it particularly bad in Peterborough at the moment? You're okay. So you don't want to be wasting money on homeopathy, do you? That's what you're saying. And how many, it's sort of glass half full, half empty. Mental health, I think, is the one thing. It's the other thing. I work for an organisation called the Doctor Support Network, which supports doctors with mental health issues. And that's the other thing that I think is really important, both in society, but particularly in NHS reform. I think the secret of a good healthcare system is good mental health amongst its workforce. I think that's absolutely vital. If you have mentally healthy staff, it has huge knock-on effects on patients. And what I see over the years is people bullied, people in constant change, people insecure about their jobs. You know the little dark lines under the eyes at the moment? You see people doing 1.5 jobs at the moment because members of staff lose their jobs and they're not replaced, or natural wastage isn't replaced. I think unless you improve the mental health of the workforce, you're not going to improve any health system. And I think very quick big bang change enforced very quickly without consent that you have deep evidence-based doubts about make people feel profoundly insecure. And I think that's why there's been such a depth of opposition to the health reforms in this country, but in any country really. You want to be involved in the process of change, you want to agree with it, and you want to do it at a pace that doesn't make your brain explode. And the reason this is most important to me, I guess, is that there are a lot of mental health issues in my family. I was brought up in Australia, and my dad was a brilliant academic chemist. He won a scholarship as one of Australia's top physical chemists to do a PhD at Cambridge. He was captain of all Australian universities' basketball team. He won awards for teaching and scholarship. He suffered from depression, which I didn't know when I was younger. And I once asked him what the purpose of life was. And he said, "There is no great purpose, there is no grand design. We're all slowly returning to room temperature." Which is the second law of thermodynamics. It's perfectly true. Didn't really inspire me in the way that Dame Cicely Saunders inspired me with, the joy of being human is to be humane. And Dad, sadly, suffered from depression and took his life. One day he was a chemist, he went into his lab and took cyanide. He took a large dose, I think, so I think it was a reasonably humane death. And when my brother and I found this out, we went and just looked at our family tree, and we thought, we've obviously got this on Dad's side, let's look at Mum's side. And we find Mum's granddad had stuck his head in the oven and killed himself in the days when you could do that. And her uncle had come back from the war and shot himself. So we stopped looking at our family tree then. And then I was trying to understand why I've never got depressed. And I didn't know about my dad's death until fairly late on in my life, because in 60s Australia, real men didn't get depressed, it wasn't talked about. And I was told when I was young that Dad had a heart attack. So I spent most of my life thinking I was going to die at 39 of a heart attack. And I was pleasantly relieved to find that my heart was probably okay. It was depression that might be the issue. And I've never suffered from depression, and it's interesting. I've done investigative journalism, I've done comedy, and I've done medicine, which is a great Venn diagram for depression. I'm bang in the middle there of three high... And I think I inherited genes from my Uncle Ron. Uncle Ron was my dad's brother, who never achieved anything in his life. And all I ever remember Uncle Ron doing, he lived in West Leaderville, he went to the same school as Rolf Harris, and all he ever did was sit on the patio in his rocking chair. And the only thing I ever remember Uncle Ron saying is, "F*** it." The great thing about an Australian accent is you can swear and it's not offensive. Any challenge that came Uncle Ron's way, if he might try it a bit, if he couldn't get on, it. And he never achieved anything in his life, but neither did he plumb the depths of depression. He lived a life of happy mediocrity. It's not always appropriate. When the kids are dying in a house fire, then it isn't the appropriate thing to do. But it taught me a lot, and actually that's probably the system I've used more than anything to survive in the NHS. I've learned, I used to be a school governor, chair of my school governors, and all this stuff would come down from the Department of Education, and you'd read it and you couldn't understand it. And the stuff that you could understand, about 80% of it, you think, how are children going to benefit from this stuff? So every Friday we get all the staff round the shredder and we'd have a it party. We'd take half of the inbox and we'd just stick it in the shredder going. We got an excellent Ofsted inspection, didn't affect the quality of the teaching whatsoever. I do that with the Primary Care Trust, I do it with government as well. If stuff comes down that I call wonk, if I can't understand it or I can't see how patients will benefit, stick it in the shredder. Delete half the stuff in the inbox automatically. If you work in any hierarchy, I bet about 80% of what comes down from on high isn't useful to you. You've got to be really bold with all the wonk in your life, really bold with all the stuff in the inbox. So that, I suppose, would be my parting message is evidence, yes, really important. Incremental change, the wonderful investigative journalism that Deb's doing, the new unit is doing, will be like a public health campaign. You'll do it and do it and do it and do it. I broke the story of the Bristol heart surgery in 1992. 19 years later, we still haven't safely and sustainably reconfigured child heart surgery. I've said if we don't do it in 20 years, I'm going to tie myself to the railings outside the Department of Health and set light to myself, which has given lots of people incentive to take it to judicial review. We have, however, and I argued this when I gave evidence at the Bristol inquiry, we now publish results for adult heart surgery, comparative results. And as I say, I broke the story in 1992. I met a very brave anaesthetist called Stephen Bolson, who was the whistleblower who gave me this information. I published it in Private Eye. Nothing happened. Published it again 4 times in 1992. Nothing happened. We finally caught up with the story. The rest of the media caught up in 1995, and as I say, the public inquiry was 1999 to 2001. What I learned then is you can't just break a story once, you've got to keep going back to it, but I also learned you have to share it with other people in the media. It's not about ownership of the story or feeling, hey, I broke a story. You have to share it widely. So now when I break stories, I've got a connection of people who I send information to, and I send it all the way up to the Care Quality Commission in the Department of Health and whatever, and people tend to act on it. But I argued at the public inquiry that we should, as they did in America at that time, we should benchmark operations that we can benchmark. We should adjust surgery for surgeons who do harder operations on sicker kids, but once we've done that, we will publish it. We know that British patients probably won't access the information that much, but we know that the very act of public benchmarking will make people raise their game, because the kind of competition we want in health systems is competitive competition amongst clinicians who want to deliver quality service. We want to compete over quality. And we know we've been publishing results now for over 10 years. Patients have got sicker, surgery has got more complex, and yet the mortality rate has halved. It's a huge success that's quoted all over the world, as heart surgery in the UK is now leading Europe. And part of that, I would like to think, although there wasn't a randomized control trial, part of that I'd like to think was the transparency. So my final message is the things I think we need to do in any health system, I call it HIT. I would say HIT. I think safety is really important, and we've not talked about that. We need the harm alarm at the front line. We need to measure safety on a ward level. We need to get an evidence base for safety. We've had these huge safety movements in healthcare systems for 10 years. We had to err is human in America. We've had an organisation with a memory in this country spent an awful lot of money on patient safety, and yet we haven't collected information in any systematic way that allows us to say patient safety has got better over the last 10 years. We've got isolated examples of success. We've reduced hospital-acquired infections, so we need to measure patient safety on the front line and compare it. My H in would be for humanity. We've got to, every time we think about, is this a humane thing? It's not just about evidence-based. Is what we're doing humane? Should we really be bringing in the 86-year-old lady from the nursing home and giving her intravenous antibiotics when she has end-stage dementia? I think humanity is fundamental to this, and it needs our leaders, from our Secretary of State to all our nursing leaders, to speak in that language of compassion, which they clearly don't do at the moment. I would be for integration, whatever it means. Breaking down professional boundaries and silos is important. I don't think if we started again, we'd reinvent doctors and nurses. I think we'd train health professionals fit for purpose. And T is transparency. I think we need absolutely aggressive transparency, not just in terms of clinical outcomes and evidence, but where the money goes. I want to know where every penny of this £110 billion a year that goes into the NHS goes. And the government said they were going to do this. They were going to have Google government. So anything over £500, you'd be able to track online. And I'm not sure we've got that now. So I want to know precisely what it's costing to reset up clinical commissioning groups, to rehire the same people who've just been fired from the Primary Care Trust, to get in all the external advice that we could have had when people were still employed by the NHS. I think we need to know that sort of information before we can move forward. But ultimately, come back to my own thing, it's about not falling in the river in the first place. And I'm encouraged that most of you think you're healthy. I think that's really, really important. I don't go near the doctor. I'm 50 now. I probably ought to know what my blood pressure is and what my prostate's doing and what my cholesterol is. Haven't got a clue. I live in a beautiful part of the Mendips in North Somerset. I have 2 dogs. I have this theory if we can prescribe dogs on the NHS instead of drugs. There's lots of evidence if you cuddle a dog, it reduces your blood pressure. They also reduce your cholesterol by eating your food. They look at the most asymmetrical side of your face, which is fascinating, and they stare at the most expressive side of your face until you take them for a walk. You go out for a walk, you're in the blue sky, the green fields, much better for you than being stuck in a sweaty gym. You've automatically got friends. Everyone you meet with another dog is a friend. You never know their name. It's always Bofus's mum or Mitzi's dad, but you sort of feel you've got a social circle. Dogs keep you supple as you bend over to pick up the poo. And if you're too depressed to put your pants on in the morning, they'll lick your testicles. You don't get that with Prozac or marriage. And I'm being flippant, but actually I come back to my original point. I think largely the causes of ill health are social, therefore so are the solutions. You exist as an organisation because you all have a passionate belief in the importance of evidence, and actually the networks that you form when you form over coffee are far more important than, well, obviously reading journals is important, but they're as important as any of the presentations that you've seen. There's a really good book you might get called Connected, which talks about the power of social networks. If you're fat, your friend's friend will put on weight. If you're happy, your friend's friend will be happier. Happiness and weight gain passes 3 degrees of separation. I've no idea how it works. I haven't finished the book yet, but a rigorous examination of the evidence suggests that we are social animals, ultimately, and what keeps us healthy is that sense of connection. So keep this community going, but to embed it in popular culture, you have to get journalists on side. Journalists are the one people. If you get a good investigative journalist on your side, it causes a huge amount of good. If you get a bad one, it can cause a huge amount of damage. Journalists are a bit like drugs, I think. And so the secret is to find one you enjoy working with to get your message across, because that's ultimately the people who can actually get that message in popular culture, get it out onto Twitter, get it out onto the front line. And that's what we need to do. We have this argument at NICE every year. Should we have NICE guidelines on coffee mugs? Should we have it, Now the pharmaceutical industry aren't allowed to have all their freebies. Should NICE take over the space that the pharmaceutical industry has abandoned? And I think those sort of gimmicks are quite good. The final thought I'll leave you is I work on the Patients Association, and I like using humorous T-shirts to flip the relationship in hospital. So we've designed one that says, "Don't touch me unless you've washed your hands," which you can wear out clubbing as well. That's quite good. The one I want to trial, and we could do an evidence-based trial, I want a T-shirt with "Please try not to kill me today." Wear it in hospital, and I bet you that they'll focus on you. They'll kill the person in the next bed, but they'll absolutely focus. A randomized controlled trial of humorous T-shirts in hospital is the next thing that I'd like to do. Okay, it's 5 o'clock. You've been very patient. Anyone got any questions? Quickly? You don't have to answer any questions. I've just talked off the top of my head, as I tend to do. Oh, it's going to be a tricky one.
No, hi. Trish Groves from the VMJ. I'm just dying to know why your book is called Sex, Sleep and Scrabble.
Well, I had this... Thank you for plugging my book. I have 3 books and 2 DVDs, if you want to go on the website. The reason I called it that is that I have this argument. When you're pleasuring yourself in a safe and sustainable way, you need lots of variety on your pleasure plate. It's a bit like fruit and veg. You need lots of little things. So you can have the sweaty intensity of sex, or you can have the wonder of looking at butterflies on your buddleia, or a beautiful book, or a walk with your dogs, or whatever. And it came from an idea about, I was talking to an audience. It's 10 o'clock on a Sunday night. Downton Abbey's finished, or just about finished. What are you going to do? The kids have gone to bed or are pretending to be asleep. How many people here would opt for sex on a Sunday night? Put your hand up. Okay. There was almost a hand up. Yes, it's all right. It's perfectly okay. Who would go for sleep? Excellent. Who would go for Scrabble? Who would try sex Scrabble? If you can't afford counselling or you're too embarrassed to go to Relate, I would recommend sex Scrabble. You can just put a word. Sometimes you need more than 5 letters, 7 letters or whatever. I don't like your mother or something. It's good. But it's quite a good way of therapeutically. I think people actually should play Scrabble before marriage, is my other point, in that you find out more about a life partner from playing Scrabble. When you play Scrabble with someone, and if you've got a nice, compassionate partner who'll be good during childbirth, then he'll just gently let you look at things up in the dictionary and graze for words, and he won't really care what the score is. If you play Scrabble with someone and they're forensically aggressive, and they laugh at your spelling mistakes, and they won't let you look things up in the dictionary, and they take the scorecard up to bed with them and laugh at you then, and tell their mates, they're going to be horrible to get married to. I think everyone should have compulsory Scrabble before marriage. It's worth another try. Can we do that one? So we're going to do a trial of humorous T-shirts in hospital and Scrabble before marriage. Anyone got any funding? Thank you. Any other questions? Evidence-based satire is the future. Evidence important, but if you can communicate it in some sort of humorous way, it will hit the button. And that's what we've got to think about. Not just whenever you stumble across some good evidence, think, can I tweet this in 140 characters? How can I actually change people's behavior? And sometimes humor is good, not always. Thank you very much. It's been a delight. Thank you.